this chapter is the first of what every chapter from this point forward is going to be like. We're going to be looking at individual systems inside the body and looking at how these different systems are, how they go through pathogenesis. And ultimately, what you will see is you probably see a lot of the same bacteria, some of the same viruses from chapter to chapter. So it just goes to show you that there's no one way for some of these, but there are for some of the others. So you just keep that in mind that you're really just talking about generalities in this class, and you'll get into more specifics as you move up through your programs. And so this is the respiratory chapter. So this is the first time we're seeing this. So when we get to the actual pathogens, I'll show you how the best way to study for them. But as we always start with a little bit of history. So this one's Rebecca Lancefield, important woman in science that ultimately figured out ways to understand pathogenesis a little better from the streptococci, so streptococcus, pneumonia, and whatnot. And so what she used was Petri plates that actually had a little bit of sheep's blood on them. And so the sheep's blood are called blood agar plates. And what this allows us to do is determine if a particular bacteria has the necessary valence factors to lyse blood. And so what we'll see, and what she discovered was some streptococci. There's lots and lots of different types of streptococci out there. Some of them would be non-hemolytic, and those tended to not be very pathogenic or pathogenic at all if they weren't able to lyse blood cells. Some of them are what we call alpha hemolytic, so we'll see alpha hemolytic right here. These have the ability to kind of screw up blood cells. We'll see that blood on the blood agar plates turns like a greenish color. And then we have beta hemolytic, which are the most nasty. Those are the ones that actually, when you look at these blood agar plates, they're nice and bright red when we first plate the bacteria on them. The next day, if they're beta hemolytic, we'll actually see a complete clearance where it's clear around where the bacteria is growing, which says that they lyse every single blood cell around them and essentially made a clearance spot on the plate. Those are the ones that we tend to be the most pathogenic. If they're able to chew blood up on a plate, more than likely they're doing some pretty nasty stuff to the blood on the inside too. So she came up with this system to be able to identify what type of pathogenesis that particular streptococci has, and earned her a place as the first woman president of one of the groups that I belong to, the American Association of Immunologists, which is a big honor for her. And ultimately also elected to the National Academy of Sciences, which is sort of like the Hall of Fame for scientists in terms of how we honor them as their life's work. So Rebecca Lancefield, we'll see the blood agar plates and hemolytic situations pop up later. The next part every chapter gets into from this point forward is talking about the anatomy of that particular system. We're not in A&P class. You all have to take a year worth of A&P. So you'll be covering more of this in there. I'm not asking you any anatomy class questions. So don't worry about knowing all the different pieces and parts. But do understand how these different pathogens interact. So here in the respiratory, we have the upper respiratory system and the lower. The upper is the head and neck. These particular diseases tend to be self-limiting and not very major. So think like colds. Then we got the lower respiratory system. These end up being, if you end up getting infections in your lower respiratory system, these tend to be pneumonia, tuberculosis, and end up being much more dire, serious, and potentially even fatal. So there's a big difference between upper and lower respiratory diseases. Here, these slides are all just anatomy slides. If you haven't had a chance to take anatomy yet and you're kind of lost in your anatomy, well, that's cool. We got some slides on it to help you understand the different pieces and parts. Again, I'm really only focusing on the upper and lower respiratory systems. So you can go through here and learn about it if you need to. So let's get through these and get to the actual diseases. All right, so this is going to be how every single disease is set up from this point all the way through chapter 27 when we finish up in genital urinary tract. So what we'll have is the name of the disease. So in this case, streptococcal pharyngitis, or if it has a nickname in strep throat. And it gives you the signs and symptoms. So sore throat, difficulty swallowing, fever. One of the things you're going to notice is that it's really hard, and this is what you need to appreciate for going into allied health type fields, is that it's really hard to discern what somebody has just by signs and symptoms, right? If I told you I have sore throat, difficulty swallowing, and fever, there's no way you'll just immediately go, oh, you got strep throat. But it's going to help you understand what possibilities there may be by understanding the signs and symptoms. Now we can get into some of the things that actually will help us identify. Throat is red, patches of pus. This tells us that there's some sort of infection going on. We get that pus, so we know that the immune system's involved. And tiny hemorrhages. This goes back to Rebecca Lansfield's work with the hemolytic cells. And so what we know is that Streptococcus, this particular agent, has the ability to lyse blood cells. And so right here is a very, very close-up picture of a Petri plate with that blood agar on it. So we see the nice bright red, and then where the bacteria colonies are growing, there's actually that clearance around them. That shows that those particular bacteria were able to lyse the blood cells. And so that's it is where those tiny hemorrhages are coming from. The bacteria is essentially lysing blood cells, causing these hemorrhages. Most patients will recover in about a week with strep throat, some basic antibiotics. So step 1, name symptoms. All right. Step 2, causative agent. Important to know what the name of the bacteria is that actually causes the disease. So in this case, it's Streptococcus pyogenes. It tells you a little bit about it. Gram-positive, grows in chains. We know that it grows in chains because chapter 3 told us morphology that if it starts with strep, then we know it grows in chains. So if you have to remind yourself of some of this morphology, go back and look at chapter 3 again. Beta hemolysis of blood cells. That's again referring to the Rebecca Lansfield way of grouping. Tells us that it's a nasty bug. Next up, pathogenesis. Now, this is the one that I think is important, but it tends to get very wordy in the book. And so what I want you to focus on is what is the important thing. So I have those highlighted. All right. So when you're going through, it's just going to be a lot of redundancy at first and getting your study skills, to the place where you feel comfortable memorizing this material. Again, lots and lots of information on here because the streptococci have a lot of different cousins, essentially. There's lots and lots of different strains of streptococcus out there. Therefore, there's going to be different types of virulence factors that each of them is going to have on board. But the most common one is going to be these two right here, the ones that are most important anyways that we see contributing to pathogenesis. We have the M protein and the G protein. M protein prevents oxidization by C3b, so immediately in your head should be a complement. So again, it's blocking complement. The protein G is binding to the FC side of the antibody. So remember, if I bind to the FC side, that antibody essentially becomes blind, or the immune system becomes blind because it can't see the antibody anymore, it can't see that constant region. So these two combined are very good at essentially camouflaging the bacteria from the immune system, at least for that little bit of time. And again, it's always a race. If I can get an advantage as the pathogen and avoid the immune system even for a day or so, that can sometimes be the difference in a serious infection versus a more mild. So again, when you're looking at pathogenesis, respect the fact in this case, many virulence factors, and that's only because there's so many different strains of this bacteria out there. The two most important are there. Here, this table goes through all the others. Please do not memorize the tables. You'll wear yourself out. That's what I consider minutia. So, the ones that are highlighted, important, ones that are on the tables, they're there if you want to see them and try to understand them, great, but not necessary to pass the exam. And then we go into the fourth part, epidemiology. This is going to talk about where do we find it at? Where is this a common occurrence? So for strep throat, it infects humans only. And so we'll see some of these diseases are able to get into vectors such as mosquitoes and ticks and mites and things like this. And some of them are going to be zoonotic, which means that they're able to infect animals and humans at the same time, equally. In this case, this one is one that only affects humans. Spread by respiratory droplets. So in this case, somebody sneezing, talking close to you, respiratory droplets are always being passed around. and contaminated food. In this case, somebody that's a food handler, not necessarily going the hygienic route and washing hands and whatnot. Or it could just be not washed properly. The food may not have been washed properly. So there's lots of different ways the food can get contaminated. And then we get into the fifth part, treatment and prevention. And so in this case, we do a quick strep test nowadays based off of the Rebecca Lancefield groupings and determining if that particular bacteria is a hemolytic version. And that's going to help us understand if the person's infected with strep throat or just another upper respiratory disease, possibly. In this case, once we get a positive test that shows that they do have it, then we can go through penicillin or erythromycin being mostly effective. And we want to try to prevent what's called post-streptococcal sequelae. So not only did we just learn about strep throat, but we also seen how the setup is, right? So we got the name of the disease with signs and symptoms. We have the causative agent. So sometimes it may be the same name as the disease. Sometimes it's going to be different. But that's the official name of the pathogen. Then we go into pathogenesis. How does it actually cause sickness? Then we go into epidemiology. Where do we find it at? And then what's the treatment? Every single disease, you're going to get tired of hearing me repeat these same 5 things, but we're going to be going through every single disease in the same way. So if you memorize and study in that type of grouping, you'll be fine. So second part of strep throat is what we call post-streptococcal sequelae. This means complications that can develop from somebody that's already been infected with strep throat. So this is going to be due to the immune system being a little over the top. One of the ways that it can happen is through acute rheumatic fever. And so this is somebody that essentially has gone through strep throat, is healthy, thinks that they're fine, and then 3 weeks later they come down with rheumatic fever. And they're going to think it's actually a secondary, they're just going to think they had bad luck and they're getting another sickness. Reality is they're actually related. And so rheumatic fever has the signs and symptoms of fever, joint pain, chest pain. This is going to be because the antibodies are now getting into the joints and whatnot, causing inflammation. So it's going to make it painful to move joints around. Chest pain, rashes, and nodules. This is all immune system, inflammation responses happening here. And sometimes they may have uncontrollable body movements, so jerking motion or shiver, uncontrolled shivering. And then for people that have this, what we worry about is the third step. So first step was getting strep throat. Second step is getting rheumatic fever. Third step is they can get carditis. And carditis is just a generic term that we use for inflammation of the heart. And so in 1/3 to 1/2 of all patients that get rheumatic fever, they can end up with carditis, and this can lead to chronic heart disease. Somebody gets carditis, it's going to damage the heart in such a way that they start losing functionality of the heart muscle. And this will be chronic. It means essentially they're going to have that for life, and there's not going to be much of a chance for recovery. So what's the responsible party here? We have the MHCs. Class 2s are going to be the ones that are responsible. It's down there on the bottom there. And ultimately, then the fourth step, if it goes even further, and again, this will be people that tend not to get treatment until it's too late. Right? And so they had strep throat, they didn't go get treatment. If they would have got treatment then and got the penicillin or erythromycin, they would be fine, more likely, because it wipes out the bacteria. For people that choose to just stay at home and say, well, I'll fight this off with some Advil or Tylenol and take some lozenges and go through the pain, well, then that bacteria, while it might clear out of the upper respiratory, it's now got into the blood system or it's been moved around the lymph and it gets into the joints, causes that rheumatic fever, could potentially get into the heart, causing carditis. And then the next step would be glomerular nephritis, essentially, which is going to be inflammation of the kidneys. And so when it gets to this point, then it's going to be very serious, potentially be fatal. Carditis can be fatal also. This is going to be damage to the kidneys. Remember what the kidneys are doing? They're basically filtrating the blood. And if you have a bunch of inflammation in there where the blood can't get through the kidneys will start to die. Because they're not getting blood, they're not getting oxygen replenished in, they'll start to die. People start getting kidney failure. Kidney failure quickly leads to death. Luckily, there's only a few strains of pyogens that can cause nephritis. And so, this isn't a very fearful thing, but it is something over the course of your lifetime, of course, your career, you may run across 1 or 2 cases of this, and understanding that it's all related back to that original strep throat. Having kidney failure can actually be completely related to strep throat that they may have had a month or so before. All right, the next one is diphtheria. Luckily, we don't see diphtheria very much because it's part of the DPT vaccine, the diphtheria, pertussis, tetanus vaccine. However, it is something that we do see pandemically. And as I pointed out before, pandemic just simply means it's a simple plane ride for somebody to bring it here to the United States. And while we have a lot of checks and balances at customs for people coming in from other places, what we're going to notice is that sometimes they may not know they're sick until they made it through there, and then they start seeing the signs and symptoms. So that's my biggest concern with a lot of these diseases. So the one big epidemic we see here is 1990 to 1995 in the Russian Federation. What happened during this time, for those of you young enough not to remember this, was Russia used to be the USSR, used to have multiple countries that were part of the conglomerate. And during Ronald Reagan's administration, they essentially knocked down those walls and gave freedom back to 13 countries that were originally independent but brought in underneath the USSR umbrella. Problem with that was you just suddenly gave 13 countries their independence. So where do they start at? Who's actually responsible for health? Who's responsible for currency? Who's responsible for a lot of other things? And so usually health ends up being secondary to trying to bring the government online. So you see here the years 1990 1995 was during that buildup where these different countries were trying to get their footing to their independence. And because of that, there was a lack of public health initiatives. And so we see a major spike in diphtheria in these areas, in these countries during that time, to the tune, as you can see there, of over 125,000 different cases and over 4,000 deaths. I don't care what your beliefs are. I've seen some of your beliefs coming back in the extra credit report for the vaccines, but that is a number that's unacceptable, right? 4,000 deaths from a vaccine treatable disease is unacceptable. And unfortunately, it was just because these particular individuals didn't have access because new country initiatives. Signs and symptoms of diphtheria, and why I think it's so important to see these signs and symptoms is that there's no way in the world, just like with strep throat, if I came into the doctor's office, if I got a little sore throat, got a little bit of a fever, 99 degrees or 100 degrees versus 98.6, and I'm just really tired. And if you've never heard the word malaise before, malaise is just that feeling of tired or feeling of sickness. You feel like, most of us have experienced, I think I'm getting sick. That's malaise. And so here, extreme fatigue, who isn't ever extremely fatigued? I know I'm constantly tired, right? So those 4 symptoms don't tell me much, right? So is anybody in here going to go, oh, well, they got diphtheria because I know that those signs and symptoms? No. And that's why it becomes so important to understand how we're able to go further and do the diagnosis. And so here somebody comes in with these symptoms, very generic, doesn't tell us much, but now we can get into some of the things that do. Swelling of the neck. So if we start feeling swelling, remember we got some lymph nodes back here, we got the adenoids and the tonsils and whatnot. Formation of what's called a pseudomembrane. Term pseudo just means fake. So essentially it's a film that we see covering the tonsils and throat. So when the doc tells you and puts a tongue depressor in and looks in there at the light, they're looking for that pseudomembrane. That pseudomembrane is going to tell them if they're dealing with something very serious or not. And so this is going to be that pseudomembrane is actually made up of dead epithelial cells. So that tells us that the immune system's involved. Clotted blood, fibrin, leukocytes that accumulate. So obviously the immune system has recognized there's a problem. And the biggest problem with these pseudomembranes is they can get loose and while you're sleeping per se, and get lodged in your throat and ultimately you suffocate. And so we've seen patients suffocate from these pseudomembranes getting loose and going down into their trachea. Heart and kidney failure, paralysis can also occur. So diphtheria is caused by a bacterium called Corneobacterium diphtheriae. It's pleomorphic. Again, going back to chapter 3 can help you remind you of all the morphology stuff here. Pleomorphic just means that it doesn't have any distinct shape. So usually we have the coccus that are spherical, the bacilli that are rod-shaped. In this case, when we say pleomorphic, it just means that they all have different shapes, and so they don't necessarily fit into one cohort. Non-modal, so no flagella. Non-spore forming, so therefore it's not a Clostridium or a bacilli. Gram-positive, that stains irregularly. So again, this will be for the pathologist, the med tech that's doing the work. They would know pleomorphic. They would know that it doesn't stains irregularly, and that would help them with the diagnosis. What is the most important part of Clostridium of Corneobacterium is that it's actually a toxin-producing bacteria. So it has that AB toxin that we discussed before, and it actually binds to the cell receptors, and it's taken up by endocytosis, and essentially kills the cell. And so again, a lot of that destruction that's leading to the pseudomembrane formation is the toxin killing the epithelial cells around it. Epidemiology, what makes a good vaccine? This is another little piece that we haven't discussed yet. What makes a good vaccine is when humans are the only reservoir. If I don't have to worry about going out, so for instance, rabies. Rabies, it's really hard, even though we have a vaccine for rabies, it's really hard to clear rabies out of nature because rabies is a zoonotic disease and it ends up in raccoons and dogs and everything like that. We'd have to vaccinate every single wild animal to get rid of rabies. Something like diphtheria, where humans are the only reservoir, ends up being a perfect disease for potential eradication if we can get enough people vaccinated that the bacteria can't survive anywhere else. We could potentially eradicate. So this is one of the things that we're always looking for when we're looking at epidemiology. Is this a disease that's found in nature, or is it only found in humans? Well, in this case, it's only found in humans. Spread by air. It's a respiratory disease. So notice there's a lot of redundancy. So remind yourself, I'm in the respiratory disease chapter. It makes sense that they all are being passed on by respiratory droplets. Or from fomites. Remember what a fomite is? Fomites are any inanimate object. Desk, computer, door handles, your cell phone, all fomite. Fomite is just a term that we give to anything that's not considered alive. And so in this case, because it's a bacteria, remember bacteria are much better at surviving outside the body. So they're going to be much better at surviving on a fomite. Even if it's just for a few minutes, upwards of a couple hours, it's able to be passed on by me. If I had diphtheria, sneeze into my hand or something, and I touch the door handle and go out, you come behind me and open that door, you now got it on your hand. If you end up wiping your face, you just essentially inoculated yourself. And so viruses don't have as good of ability to survive on fomites, even though we will notice a couple that do. Bacteria are the ones that tend to survive better on fomites. What's the difference between pleomorphic and polymorphic? Poly we don't use as much. Pleomorphic's really they would mean the same thing. But pleo is a word that we use more often. All right, so treatment and prevention. Obviously, as we talked about before, for a toxin-producing bacteria, the first thing we have to do is block that toxin. We'll worry about clearing out the bacteria later, but we need to get that toxin under control. So the very first step is to inject the anti-serum or the antitoxin. Delaying it can be fatal, right? 4,000 individuals died of the last major outbreak we had in the Russian Federation. Antibiotics will clear the bacteria, but again, what it's saying there in that third bullet is that we have a problem because of the toxins already out in the bloodstream. It doesn't matter if I kill the bacteria, we got to get that toxin going too. So it's a dual-fold effort. We have to go after the toxin with the anti-serum. We come in behind it with antibiotics to clear out the bacteria or the source of the toxin. However, why immunization is such an important feature here is that even with all the therapy in the world, we still have 10% mortality. So 1 out of 10 people that come in with diphtheria will die. And that's worldwide. So it's also going to count in healthcare systems and whatnot of these different countries. But ultimately, 1 in 10 will die that get diphtheria. Immunization, incredibly effective. It's a single bacteria. It doesn't mutate. And so for now, as long as it doesn't mutate and there's only one bacteria that causes diphtheria, the vaccination is beautiful. We don't ever see people coming in with diphtheria that have been vaccinated. So it's incredibly effective. All right, this next one is just a generic one, so I'm just going to cover it in very generic, just like it's done here. But it's covering 3 major diseases that you'll see quite a bit, especially if you end up working in an ER setting or an urgent care setting. You're going to see these 3 on a regular basis. And so they're all covered together. They're all respiratory diseases, but we have pink eye, also known as conjunctivitis. We have earaches, also known as otitis media, and we have the sinus infections, which is sinusitis. So you have the 3 generic names up there, and then you have the 3 medical names or diagnosis names that we give them. And they're mainly caused by 2 bacteria. One is Haemophilus influenzae, the other one is Streptococcus pneumoniae. Both of them are what we consider to be normal flora, and so both of them end up being opportunistic pathogens. And the last part there, you see 1/3 of all 3 of those can also be caused by viruses. So it's important to know if the person is infected with virus or bacteria in terms of knowing if we give them an antibiotic or not. So pathogenesis of conjunctivitis, very few details are known, but we figure it's probably an airborne respiratory droplet or contaminated hands. We know that both those bacteria are able to resist destruction by lysozyme. So go back and look at chapter 14. Remember, lysozyme is an enzyme that breaks down peptidoglycan very generically. It's part of the innate system. It's found in our tears, found in our saliva. So again, conjunctivitis being pink eye, well, the bacteria has to be able to get around lysozyme. Well, perfect, it does. And so it's going to be able to infect the eyes very easily. It attaches and starts releasing all kinds of nasty enzymes, proteases, generically breaking up proteins, collagenases, breaking up collagen, coagulases, blocking, clotting, where the blood tries to clot, and hold the bacteria in there. Have coagulase, be able to break through that, helps the bacteria spread. And sometimes, depending on which strain it is, we can get some toxins.
So the poop in the eye thing is not real.
It could be. If you had poop in your hand and you touched your eye, it could easily transfer because both of these are bacteria that are part of the normal flora. So yeah, partially true. It's not the only way, but yeah. So otitis media and sinusitis are essentially related because there is the pathway there, the eustachian tube that connects between the nasal area and the ear. So this is a nice little highway essentially for the bacteria to take. So something that starts with an ear infection can move to sinus infection pretty quickly by traveling down that tube. But what we mainly see is what occurs. You have your main ear canal, you have your eardrum. The bacteria actually travels up from the nose to the ear. Sometimes you can go that direction. And starts building up behind the eardrum. And this is going to cause immense amount of pressure, some hearing loss, especially during that acute phase, pain, obviously. But what we worry about the most is going to be that pus accumulating behind the eardrum. And potentially the eardrum can burst. And now you're going to have permanent hearing loss. So this is a major concern. And where do we see ear infections the most? We see them in children, especially young children. The reason being that we see them in young children is that their ear canals are more shaped like this when you're first born. And as your head starts elongating, your ear canals start getting even, and as an adult, they end up going like this. And so as an adult, we don't get ear infections much, the bacteria rolls out of the ear. As a child, especially as an infant, your eardrums are still like this, so the bacteria is rolling right in to the eardrum. It ends up being, so for instance, my son had ear infections every damn month almost for 2 years and constantly fighting them. And eventually we can go in with ear tubes and things like this. But that's what we see up here. Epidemiology, we have carriers. Over 80% of us are carrying these bacteria. So that tells us it's normal flora. But it's when it's opportunistic and it gets into places it shouldn't be, or for instance, in infants where the ear canals are facing down, it allows those bacteria to roll down and get into places they're not supposed to be.
So as a teenager, like their ear canals would be
More even, or even already formed as an adult. Yeah. So that's what we see here. Otitis media or ear infections, rare in the first month of life, but common in early childhood. After the normal flora starts establishing itself, that's why it's rare in the first month, because the normal flora is not quite there yet. Increased risk from pacifiers beyond the age of 2. Again, that sucking, constant sucking, motion, constantly moving the eustachian tube. It constantly keep pushing bacteria in the areas they're not supposed to be. Older children develop immunity, so rare after the age of 5. So it's just that little window, usually between ages 1 and 3, that we see the biggest surge in ear infections. But what else can actually list it? People have nasal allergies. So if you have allergies that always get in your nose, it could eventually spread through the eustachian tube up to your ears. So, sometimes people will progress from an ear infection to sinus infection, or sinus infection to an ear infection, and sometimes even goes to conjunctivitis too. Just depends on the modes of transportation here. So treatment and prevention. Well, treatment's going to be antibiotics. Usually we have to do it through drops, because again, most of us are just used to taking a pill, and a pill makes everything all better. Well, the reality is taking a pill is not the best way sometimes. To get the antibiotic up into your ear canal, why would I take it through the mouth, process it through my stomach and intestines, and then hope that it makes its way back up to the ear? It doesn't make any sense. So for people that have ear infections, we tend to use an antibiotic that's in a droplet where we're putting it right into the ear canal. And we use this, it helps decrease the risk of complications. In this case, it's okay to give, especially a child, antibiotic drops when it may be a virus. Why? We don't want that ear canal bursting, right? So we're not going to risk that chance that it may be a virus, and so we're not going to give antibiotics. No, let's go and give antibiotics if they're having a very painful ear infection, because we don't want that to eventually burst that ear canal and then have permanent complications down the road. And since we're giving it in a droplet form, we're minimizing any chance of destroying any of the normal flora of the intestine and whatnot, because it's not going in that route, it's just going straight into the ear. So decongestants and antihistamines, this is going to be mainly for adults that get ear infections and sinus infections. The first thing you try to do is relieve that pressure. So you'll take all kinds of allergy medications, but they're generally ineffective and can actually reduce the immune response. So this is another example of masking the signs and symptoms versus treating the problem. If I mask it, sure, I might feel better, but it's going to take a lot longer for myself to heal, because I'm basically dumbing down my immune system's response to the point where it's not able to do a whole lot. So it's just delaying the actual clearance of that disease. Preventive measures is going to be hand washing. Again, avoiding touching your eyes. Conjunctivitis is a terrible situation. Usually you end up having photophobia. So even the littlest bit of light is too intense and can actually cause eye pain and cause even eye damage sometimes in serious circumstances. So conjunctivitis is probably one of the worst of these three. And then ultimately, you've all heard of ear tubes. In this case, it's a little tube that goes in there, helps open up the ear canal and essentially allowing more air in there, changing the shape of it a little bit to try to minimize any future bacterial infections.
With the sinus infection, what's the quickest way for the antibiotics to get sinuses?
With the sinuses, that's usually one that you take a pill for, because then you're trying to get up into the blood and whatnot. Here, so now we switch over to viral infections and upper respiratory. So notice that we switched over, so always pay attention to the top of your slides. Tells you where we're at. So now we switched from bacterial infections to viral infections. So now we're focusing on viruses. Average person gets 2 to 5 per year. So that's average, right? So you may look at it and go, I was at 6 last year. Well, unfortunately, there's somebody out there that was 6 or 7 times in order for the average to work out. And so we've all had a cold. We know what it's like. It's usually self-limiting, usually some pain, maybe a little bit of fever involved, but for the most part, benign, annoying disease. And so remember that is part of the upper respiratory diseases. Upper respiratory tend to be the more or the less dangerous, despite diphtheria. So common cold, most frequent, accounts for over half of all the diseases. Again, signs and symptoms, nothing there is going to be novel, right? Malaise, sore throat, runny nose, cough, and hoarseness of voice. Again, it could be anything. Nasal secretions are watery, and that's going to be a big tell. If you have watery, clear to yellow snot, that's usually viral. If it's green, dark yellow to green, it means it's switched over to bacterial. So it's a big tell sometimes. It's not always 100% guaranteed, but that's a big tell. Light yellow versus dark green, viral versus bacterial. So in this case, nasal secretions start out watery, then thicken to green. That ends up being the secondary bacterial infections that sometimes come in with somebody that's already got a cold. You got a viral infection, your immune system's busy fighting it, sometimes allows a bacterial infection to develop, usually from an opportunistic pathogen that's already there. So no fever in a common cold unless you have a bacterial infection. Viruses, in this case for common cold, don't cause fevers. So if somebody comes in complaining of all this sneezing, snot, a lot of this, and they're like, oh, I want an antibiotic, but their snot is clear, yellow, light yellow, and they have no fever, they get no antibiotic, right? Because they don't have a bacterial infection at that moment. Now, if they, usually what the doc would then tell you is, they'll come back in a few days if you're still feeling bad. What is that going to tell us? That tells us that a secondary infections probably come in if you're still sick a few days later. At that moment, then we will give you an antibiotic because there's a potential that you have accumulated a secondary bacterial disease. Most symptoms are going to be gone within a week. Again, not telling you anything novel because everybody here has had a cold, I'm sure. Now, what are the causative agents of a cold, and why is it that we get them all the time if we develop immunity? 100 plus types, just of one family. One family of viruses called the rhinoviruses. Again, remember, viruses are not considered alive, so we don't categorize them the same way as we do bacteria and fungals and whatnot, where they have a genus species. Viruses aren't categorized. They actually get categorized in their own weird methodology that I never got privy to all that much. So they just get grouped into these families. And so rhinoviruses is one family, over 100 different types. That means you have to get infected with every single one before you accumulate all the immunity. You would have, so you get infected with rhinovirus 1, you'll get cold. Maybe in a few months to a year, you get infected with rhinovirus number 5. You don't have immunity to 5. You only have it to 1. So because there's over 100 types just in that one family, tells you that there's a lot of opportunities for you to get sick. Members of coronavirus is another family name. There's also quite a few in there too. And so these are going to be the two biggest that cause common cold. The pathogenesis, again, lots of verbiage here, but all the same stuff we've already covered. We have to have attachment, right? So the first thing that has to happen is that virus has to attach to the receptor that it's looking for. So we have attachment, gets inside, it starts increasing the number of viruses that's inside the cell, right? Because first thing someone's attaching to our cells, infects the cells, increases its number, and then it's going to have to break out. By breaking out, it starts stopping up the ciliary motion of the mucociliary escalator that's pulling all the mucus up out of the lungs, shuts those down. Now the mucus is all stuck down in the bottom of the lung. This is going to cause you to start coughing, start trying to pull up that mucus in different ways. That's therefore increasing your secretions, mucus secretions, tissue swelling, sneezing, because that mucociliary escalator shut down. We're going to have the immune system coming in, starting to release cytokines and inflammation, right? So nothing new yet. This is, even though there's a lot of verbiage here, it should make sense because it's just in a sequential manner. Blood vessels dilate, letting the leukocytes in, and you're going to possibly have spread. If the virus is able to spread, usually due to lack of medical care or just bad luck. It may spread pretty quickly. And then, because it is a minor infection, the immune system is ultimately going to win. It's just going to be dependent on your own luck, whether it's going to happen sooner than later. But very, very, very rarely does anybody have fatal or chronic conditions from this common cold. So epidemiology, where do we find it at? Humans are the only source of rhinoviruses and coronaviruses, so we don't necessarily get them from a dog sneezing on you or a cat sneezing on you. It's going to have to be a human. Airborne droplets are inhaled also by touching the eyes, nose, basically any way that virus can get into your body. So touching your face, could eventually help spread it straight into the body. Transmission is much more likely during the first couple days of infection where the virus concentrations are the highest. First couple days of infection, you don't know you're sick. So for you to be upset that somebody that was sick that came to work and you're like, oh, that's where I got it from, probably not. You probably got it from them when they didn't know they were sick and pass it on to you, and you end up developing it just maybe a day or two behind them. This is a genius way for the virus to hide itself. It's a brilliant camouflage mechanism. Why, if you were a virus, would you let your host know that you're infecting them until you're ready? And so in this case, having yourself or the virus hiding itself for the first couple of days or being at the highest capability of being spread in the first couple of days when the host doesn't know that it's sick is optimal, because when the host knows that it's sick, what's the host going to do? Stay at home, stay in bed, limiting the capability of this virus to be able to spread through respiratory droplets. Instead, keeping itself hidden, allowing itself to transfer faster between people is ideal. So nearly, it takes upwards of a few days after you've been infected for you to know that you're sick. And then after that, it can be upwards of 2 weeks before you're fully healed. But during that time, you're not very infectious anymore. So only a few virions are needed. So virion is the singular for virus. So in this case, it's just you only need a few virus particles to cause sickness. Reasonable prevention is great. Washing hands, all the same things we hear during cold season that we're getting ready to come into now. All the same things you hear are still applied here. Final thing, how many people have gone or have heard, or maybe they even use it themselves, that colds are caused by not wearing a jacket when it's cold outside? I know my mom yelled at me, you're going to catch a cold, put a jacket on. There is no evidence that low temperatures are the cause of colds. What does happen is when it gets cold outside, what do we tend to do? Do we do a lot of stuff outside? We stay inside. What does that do? That allows us all to be within proximity of each other, spreading it much easier. And so especially, it's not as big of a deal down here, even though it does get cold. Places up north where it's impossible to be outside in the winters, you're all inside congregated, much easier for the disease to spread. Also, one of the things that we notice happens in cold weather is we get dried out a little bit. So your sinuses dry out a little bit. What's one of the very first things that's important for your innate system? Mucus. If you don't have that mucus and you're dried out a little bit, it allows you to be much more vulnerable to a virus. So there's no correlation. It's actually been studied to death. No correlation between cold weather, you being cold, and catching a cold. It's actually being in closer proximity and dried out sinuses more than anything. All right, so no proven treatments for the cold. You just got to wait it out. So no antibiotics for you. Analgesics, which are going to be basically Advil, pain relievers type idea. And antipyretics, anti-fever medications are going to reduce the symptoms, but can ultimately prolong the time that you're sick. Again, same idea. You're basically knocking down the immune system's ability to do its job. Preventing spread through hand washing, touching face. Preventing touching faces, avoiding crowded areas can be good. And there's no vaccine due to the ridiculous number of rhinoviruses or coronaviruses that there are out there. The best that we can do with a vaccine, and we're now getting more into vaccine discussions, is we can do what's called a trivalent, which means I can have maximum of 3 potential strains in any given vaccine. where there's a couple companies out there testing tetravalent, 4, but right now the maximum we can do is 3. So when you have over 100 just in the rhinoviruses, that means that I would have to have at least 30 plus different vaccines just to prevent the cold. Not something that's economical, not something that's even feasible in any sort of fashion, especially when the cold is self-limiting and rarely causes any chronic problems. All right, now we switch over to one that is a little bit more of a pain, adenoviruses. So adenovirus is just another family name, just like rhino and coronavirus. But this is going to be a virus that actually causes fever. So this is one of those weird ones. I just told you, you don't have a fever, it's probably, you don't have a fever, it's probably virus. Well, in this case, adenoviruses do cause a fever, but it's going to come with some other tells. You're going to end up having pus on the pharynx and tonsils. So yet again, doc can go in there with a tongue depressor and a light and take a look and you can see the pus on there. That's going to identify that it potentially is an adenovirus. The lymph nodes are going to be swollen again just from inflammation. Conjunctivitis or diarrhea may occur. So if they come in with pink eye or complaining of diarrhea, and they have this pus, then you might be sorting over to it being an adenovirus. Severe cough and chest pain could be confused with pneumonia. Could even be confused with whooping cough. And whooping cough is going to be something more serious that we'll talk about here in a little bit. And pleurisy is when you have blood, in the lungs. And so sometimes all this can be potentially all linked together. So causative agent, again, over 50 different types because viruses, they mutate a lot. There's a lot of different variations of them out there. Again, because they're not specific genus and species, we just all lump them into one family. So it's not surprising when we see 50, 100 different strains in one family name. Can remain infectious in the environment for a long time. So again, what this is telling us is that they're actually pretty good at surviving outside the body, which is a rarity for viruses. Resist destruction by detergents, alcohols, heat, chlorine. So it really is hard to kill or hard to get rid of. Pathogenesis, same as we've seen before, has to attach. Again, when you're studying, try to find the similarities and differences. Similarities, they all have to attach. They all have to infect somehow by attaching. So you shouldn't have to memorize all of these individually. Just kind of group them together. Say, okay, they all kind of go through the same process here. What makes them different? Well, in this case, it's avoiding host defenses. Again, nothing new there. Just giving you a small list of defenses that it's avoiding. And then it's following replication. It's basically killing off the cell. Nothing surprising there. All viruses do. They have to kill the cell that they're infected in to be able to spread to more cells. And so the epidemiology, yet again, humans are a reservoir. If there wasn't for the fact that there was 50 plus strains, it would be a good candidate for a vaccine. But we can't really do that with all the different variations out there. Crowded conditions, like we just discussed for common cold, is the way that it spreads. People that after they've even healed or they're not displaying any signs and symptoms themselves anymore, they're actually still shedding the virus in their respiratory droplets and also their feces. So again, spreading can happen, and while you may go, that's gross, but at the end of the day, think about things like daycare workers, think about things like nurses and whatnot that are working with potential invalids or people that need help. There's a lot of contact of fecal matter, and so this allows for spread pretty easily in clinical settings like that or daycare nursery settings. Also, because chlorine doesn't kill it, it can be spread in pools. And again, you'll hear me say this a couple more times probably before the end of the semester. You don't find me in a public pool. It's because of things like this freaking me out. You become quite a hypochondriac teaching this class over and over and over again. So infected chlorinated silent swimming pools. So another case where, again, as an epidemiologist, if you're interested in continuing your career and you're still trying to sort out what you want to be when you grow up, an epidemiologist, this is their job, is to understand these type of situations. And when we see 3, 4, 5, 6 different people coming into ERs, all displaying an adenovirus type infection, then we start asking the questions: where have you been? Where have you been? What have you been doing? And we try to find those linkers to what they all have in common. And we've learned that pools are a source, especially, trying times like we're in now where you don't have the budgets and they try to cut back on the amount of chlorine they're putting in the pool to save some money. You end up with situations like this sometimes. So treatment and prevention, no specific treatment. Most patients are going to recover on their own, even though it does have this more serious situation with the pus and the pain in the tonsils that you don't get with a common cold. You get that fever that you don't get it with a common cold. But it's still going to be all right. There was an attempt on making a vaccine for the military, but was abandoned due to cost. And despite the fact that we still see quite a bit of adenoviruses, there is information out there saying that we are trying to build a vaccine, relying on the idea that there's only a few of the strains that we see the most regularly. And so if we build a vaccine against those, we can hopefully at least knock out the big cohorts of people getting infected with it. All right, so now we're switching gears. We're going down to the lower respiratory system. So remember, the biggest change here is that diseases in the lower respiratory system tend to be much more serious. So far we covered things that are benign, colds, things like this. Now we're going into things that ends up being more serious. So the first one here, pneumococcal pneumonia, accounts for over 60% of all adult pneumonia patients requiring hospitalization. So somebody ends up acquiring pneumonia and needs to be hospitalized 60% of the time. It's going to be pneumococcal. Signs and symptoms: cough, fever, chest pain, sputum production, pus and blood may be coughed up in the lungs. That's going to be a big tell that there's something serious going on in the lower areas. But before that, you're going to have only a couple days of runny nose and congestion. They may think that you just have a cold. So again, delaying treatment and allowing these diseases to manifest themselves full blown is a lot of times the downfall. But again, you have a runny nose, how many people are running to urgent care and calling up their doctor? Right? Not many, right? So again, these are going to be some of the signs and symptoms that we can see, but it doesn't tell us that it's going to turn into pneumonia. Sputum is going to be pinkish or rust colored because of the blood. The blood is in there because of the inflammation, basically dilating the blood vessels, trying to get the leukocytes up into the lungs. Severe chest pain, again caused by all that inflammation going on, causes rapid, shallow breathing. So this is a definite symptom that we can see. So somebody is just having very shallow, having trouble catching their breath is telling us a big sign. The patient will start getting a dusty color to their skin, telling us that they're not getting proper oxygenation. So you start seeing this like grayish coloring of the skin, telling us, okay, they're not getting enough oxygen. But we can read that with the O2 monitors too. We can see that. We don't necessarily have to rely on seeing it in their skin color. So without treatment, survivors show profuse sweating and rapid return to normal temperatures within a few days. This is going to be somebody that is not immunocompromised, somebody that is not young, not old, that gets pneumonia. Most people are going to need extra help, but people that do not get treatment and survive, they're going to be your healthy cohort, pretty much our ages type people. Causative agent, Streptococcus pneumoniae, again, a part of our normal flora. So nothing that would suggest to us that this particular disease would be dangerous. Again, because it's part of our normal flora. Gram-positive Diplococcus. Remember, Diplo just means it has two of them next to each other all the time. It has a capsule. Remember, capsules are important for hiding from the immune system. So again, it allows it to buy time to cause disease. There's over 90 different serotypes. Again, it makes it difficult to stop with a vaccine because there's so many different variations of it out there. And strains that don't have that capsule are not pathogenic. So there's Streptococcus pneumoniae out there that doesn't have a capsule that is a pathogenic. So the capsule is a key piece of its virulence factors.
When you said Diplococcus, you meant the shape, right?
The shape, yeah. So coccus means it's circular. Diplo means there's two of them. So yeah, so it just goes. It helps you. It's mainly for pathology med techs. If they see that underneath this, it should be like an immediate Streptococcus. Pathogenesis, again, a lot of this redundancy stuff here when we look at pathogenesis. Encapsulated, having that capsule, it gets inhaled, gets down into the lower alveoli where it starts multiplying. Again, it's a bacteria now, so it's multiplying through binary fission, causing the inflammatory response. We get the same thing we learned in chapter 14 and 15. All the different neutrophils and macrophages come to that site. We actually have macrophages right in the alveoli called alveolar macrophages, so they're right there. They're going to immediately start the inflammation response. But as you can see there, the capsule actually blocks complement. So now the bacteria is winning through the innate system, through the complement system. We have to wait for adaptive to come on. In that meantime, all that accumulation of all that crap in the alveoli, whether it be the bacteria, all the different cytokines, chemokines, macrophages, neutrophils, is minimizing the space for air. And so therefore, it's going to be harder for them to capture their breath because they have all this other stuff blocking the airways. And so it's going to cause them to constantly keep coughing. That's just involuntary to try to pull things up out of the lungs. So you have the coughing and shallow breathing, a lot of sputum, maybe some blood in there because of the inflammation. It's basically them coughing it up. However, the problem becomes is if, especially in immunocompromised patients, is that because we have this dilation of the blood, the bacteria can actually go the opposite way too. The dilation of the blood vessels are there to allow the neutrophils and the other immune system cells to get into the site of infection. But since I opened that door, the bacteria can also go out sometimes. And that's what the last one's telling us, is that it can enter the bloodstream and lead to sepsis. So if the bacteria can escape from the lungs, it can lead to sepsis, and also lead to endocarditis, which again is the inflammation of the heart muscle. Meningitis, you get into the brain, spinal cord membranes, which we'll cover. Probably will be a self-study chapter. I think it's chapter 25 or 26 is the nervous system. That's when everything goes downhill. Instead of it being only a 10% chance of mortality when it's just pneumonia, when it becomes meningitis, it's 90% and above. So when it becomes that serious, we have a major problem with these particular patients, even surviving a few hours after meningitis sets in. So epidemiology. Well, here's the problem. Over 30% of us carry it as part of our normal flora, even the encapsulated version. As long as it's in a place where it's supposed to be, it's perfectly fine. It's when it gets into the lungs or gets into places it's not supposed to be, blood and whatnot, that causes problems. The rate of infection increases when there's any sort of compromising situation to your natural immune system. So alcohol, again, alcoholics type situations where they're basically destroying themselves through alcoholism. Narcotic use, again, anything that knocks down your immune system's ability to function correctly can increase the chances of you getting sick. Heart, lung disease, diabetes, cancer, anyone over the age of 50, all predisposed for potentially pneumonia. Luckily, treatment and prevention is pretty easy. If we get that person into the doc or into the clinic or into an inpatient situation early, penicillin and erythromycin work just fine. So we can just give them standard first-gen antibiotics. But we are seeing resistance to those coming up. There is a vaccine available. And now I did just tell you that, vaccines are only trivalent. So you're like, that one says 23. It just so happens that it still only has 3 bacteria in that vaccine, or 3 parts of the bacteria to that vaccine. But because they're very similar, they look very much alike, even though we can't, as scientists, underneath the microscope, we can see subtle differences. These 3 strains that we put in this vaccine actually give us coverage to 23. And so just because they're so similar, the immune system recognizes them to be the same. And with these 3, we get protection over 90% of them out there. Now, it's not a common vaccine yet, but it's starting to make its way in. We actually see this other strain that is going to be available for kids and infants to help try to fight off early stage pneumonia also. So, it's there, but it's not a very common one.
So it says we carry the encapsulated pneumococci in our throat. the mucociliary, is that some kind of like cilia that's pushing it back up instead of
It's in your
letting it
trachea.
fall?
Yeah. So your trachea is lined with the mucociliary escalator that helps pull mucus up naturally. It's always pulling it up. When it gets shut down, then all that mucus gets stuck down in your lungs, and that's what causes the coughing to try to push it out.
So when you feel it in your chest, the mucociliary, the cilia can push it back out, but
Yeah.
if it's going
If it's
in,
shut down by the virus, then everything's stuck down there.
Okay.
Yeah. So next one, Klebsiella pneumonia. Still causes pneumonia-like symptoms, so everything there should look pretty much the same in terms of signs and symptoms. But this is a different bacteria called Klebsiella pneumonia, and what it has a pretty distinct shape of looking like a club. So it has a little bit of a knob on the end of it. So it's one that's pretty easy to diagnose with any simple pathology. But the biggest thing here is it's the most common hospital-acquired pneumonia. So this is somebody that comes into the hospital with a different reasoning for being there. Maybe they came in for surgery, maybe they came in for some other treatment, and they ended up developing pneumonia during their stay at the hospital. The grandest majority of them end up being Klebsiella.
so that's not part of the normal.
No, this isn't a normal microbiota. So pathogenesis, again, respiratory, so it's inhaling it, contact, medical equipment, ventilators can have it on it. Again, this is going to be places that either high turnover where they don't have the time, like an emergency room where they may not have the time to properly clean equipment between patients, even though they should. A lot of things are being switched over to disposable, one-time use things, so that's helping get rid of a lot of these problems. But places where that's not the case, sometimes we end up with bacteria in the devices themselves. So Klebsiella is going to colonize the throat, get into the lungs. Those adhesins are going to help colonize. Again, nothing new there. This is the way bacteria work. They have those adhesins that help them stick. Capsule is important too, just like it was for the one before. Capsule is very important for how it's able to avoid the immune system. Again, interfering with complement, so blocking that opportunity, giving it time to increase its numbers. And then we end up with tissue death and lung abscesses. So Klebsiella will actually go in and destroy the lung tissue. And when that happens, that ends up being permanent damage. So people that end up with Klebsiella infections are going to end up with permanent lung damage. Essentially their lung capacity is going to be minimized. And often enters the blood. If it's so good, again, these two, it's just those critical thinking, type, process you got to do at home when you're studying, is if the capsule is virulence factor blocking complement, that means that we're going to get higher numbers of these bacteria going up. Therefore, these bacteria are really good at killing the tissue and causing abscesses in the lung, which are holes in the lung. So then this next one makes sense. It often enters the blood. Well, sure. If it's causing abscesses, of course it's going to get into the blood. It's just burrowing right through the lung and causing permanent damage to the lung, and it's getting into the blood, causing more abscesses around the body and endotoxic shock. Why? Because it is gram-negative, right? So gram-negative, Rod. Gram-negative, remember, endotoxic is only caused by what? LPS, right? So LPS is only found in gram-negatives. So here, seeing endotoxic shock should automatically go, well, it's got to be a gram-negative. Gram-positives can't cause endotoxic shock. Epidemiology, widespread in nature. So this is our first one that we see that we can acquire it pretty much anywhere. It's ubiquitous. So we find it in all parts of nature. Young and old, compromised immune systems, all are going to be important, as we've seen time and time again. Young because their immune system is not fully online. Old because their immune system is weaning. And immunocompromised because, you don't have your immune system working all that well. Strains circulating in hospitals, nursing rooms, often resistant to antibiotics. Why? Well, they've passed through a whole bunch of patients and they've already been, essentially blocked, learned their resistance. So that makes sense. Increasing multi-drug resistance in Klebsiella. So this is a serious concern. It'll be part of your training, safety training and whatnot for those who end up working in hospitals or nursing homes. You're going to learn that these are some of the more important ones that we worry about. Treatment and prevention. Antibiotics are effective if that particular version of Klebsiella is not resistant. We can do sensitivity tests in the medtech labs to determine which antibiotics are going to be the best for that particular person, that particular strain of Klebsiella. However, if we can't find the right antibiotic, we have a pretty high death count. Over half the people are going to die to end up with Klebsiella infections, mainly because we don't have a good effective antibiotic to give them. We can do surgeries to go in and drain the abscesses if it's that serious. If it is blocking something or clotting something, we can go in and drain them. But at the end of the day, that's really not going to be much more than the deterrent buying a couple extra days. That's really not going to be a end-all be-all cure. All right. Next type of pneumonia is mycoplasma. So you see how this gets redundant. So hopefully you're thinking to yourself ways that you can study this material a little bit easier when you get home. Definitely don't wait till the day before the class, the exam to study this, because it is quite a bit. But you can definitely put it in ways that make sense. So here's another type of pneumonia, mycoplasma, another type of bacteria. We can see it right there at the top, bacterial infection. Signs and symptoms, onset is gradual. This is what we call walking pneumonia. Pretty much everybody acquires this at some point in their life, usually in their early 20s, but it can happen as late as 40s, 50s, and whatnot. This is leading pneumonia of college students and also military recruits. What's similar between those two? Dorms, age bracket, right? They're all being thrown into barracks together or dorms together. Not necessarily college age like you all, because we're a commuter school, but we're talking about schools that actually have on-campus housing, dorm systems. They're going to end up having higher numbers of walking pneumonia because they're all basically piled together. It's a respiratory disease, so they're spreading it amongst each other pretty easily. Onset is gradual. That's why we call it walking pneumonia. People walk around with it not knowing that they're sick because it's gradual onset. Initial symptoms are just fever, headache, a little bit of muscle pain, fatigue. Again, nothing there is going to leave you sitting at home. You're going to wish that you had some Advil, and you wish that you might feel a little bit better. Whatever your secret concoctions are, maybe a shot before you go out. Whatever your favorite drink is, but ultimately just trying to get rid of the signs and symptoms that you are just feeling that just kind of are benign, but also annoying. Dry cough after several days. So now we got a couple weeks have gone by. Start coughing, dry cough. That means there's no mucus in it. So again, nothing to tell us that it's something serious. Mucoid sputum will be produced later, so you start getting mucus in it, and you might get some ear infections in a very small population. But again, nothing there that is going to leave you bedridden for the most part. So that's why we call it walking pneumonia. People just go, oh, well, whatever, it's not enough to keep me home. Causative agent, mycoplasma pneumoniae. So remember here, myco means that it's mycolic acid and not peptidoglycan. So it's not gram-positive, not gram-negative. So it's going to require a different type of treatment. Small, easily deformed bacteria lacking a cell wall. Again, it's myco, so it doesn't have a cell wall. Slow growth, instead of being every 30 minutes to 20 to 30 minutes. Mycos tend to be every few days before they replicate, so much slow growing. Therefore, it's much more difficult to get an antibiotic to stop them. Even a bacteriostatic antibiotic, if the bacteria is not growing very fast, that bacteriostatic antibiotic really isn't doing a whole lot either. So you have to stay on the antibiotics for a long period of time. But for the medtechs, they have a very distinguished look to them when they're grown on Petri plates. They look like fried eggs. And so it's pretty easy for a medtech or pathologist to determine the causative agent just growing it on the plate. So a few cells you inhale can start it. They have to attach. They interfere with the cell reactions. So again, nothing new there. Same way all these are working. Inflammatory response is going to basically be the macrophages coming in, tries to wall off the mycoplasma because the same way it treats tuberculosis too, tuberculosis being a mycoplasma also. It essentially walls it off and tries to just hide it, causing those granulomas that we talked about in chapter 14. Epidemiology, you spread from respiratory droplets. You're actually spreading it for quite a few weeks afterward. That's why we see such large numbers of college kids as well as military recruits getting it all at once because, well, it spreads pretty easily. Most people don't know they're sick, and they're spreading it amongst their peers, quite quickly. Immunity following recovery is not permanent. So you can get this disease more than once. Why is it not permanent? Mycolic acid is a lipid. And remember, lipids don't make a very good antigen for the immune system. So the immune system kind of forgets what mycoplasma looks like. And so we can actually see people that accumulate or actually acquire walking pneumonia again, even though it's the same bacteria causing that disease. There's no preventative measures besides avoiding overcrowding, which may not be a choice for a lot of people, depending on if they went to school of dorms or they joined the military. It's not an excuse. You can't go tell your commanding officer or your residence manager that you don't want to be in the dorm or don't want to be in the barracks. It's not an option. So sometimes overcrowding is not something we can avoid. Tetracycline and erythromycin, both second-gen drugs, work if it's given early. But like I said, it's bacteriostatic. So it only slows active growth. And since they're growing so slow, you have to be on these antibiotics for weeks, sometimes months, to make sure that you've actually cleared the disease completely. All right. We've got about 4 minutes left. So I'm going to get through some of whooping cough, but if I can't make it all the way through, I'll stop. So pertussis is whooping cough, part of your DPT, so diphtheria, pertussis, tetanus. So now we're hitting on the second that's in that vaccine that you get as a child. This is a vaccine preventable disease, as I just said, but we're seeing this popping up all over the world, all over the United States. We're seeing pertussis. A couple kids in my neighborhood over at Algiers Point had it just a couple months ago. So we're seeing it actually coming on more and more, and we're still trying to sort out the reasons for that. They were vaccinated. So the question is, are we getting more virulent strains of whooping cough, or is there something else happening here? So we got over 500,000 deaths annually from this disease. It's a disease that we tend to see only in infants, and so this ends up being an even more dire of a situation. It has 2 stages. It has the catarrhal stage, which is going to be just mainly an upper respiratory disease. The baby's going to have a little bit of a cold. It's not going to immediately be enough to say, oh my God, it's pertussis. It's going to have some cold-like symptoms, or the child's going to have cold-like symptoms, and sometimes it'll go away, and that's the end. It's when it turns into the proximal stage that it ends up being serious. The proximal stage is going to be the frequent burst of violent, uncontrollable coughing. This is actually how the disease has decided to spread. If it causes the child to cough so violently that it's pushing the bacteria out of the lungs at a high rate of speed, it's got a better chance of spreading to somebody else that might even be, a few feet away. Because it's so violent, there ends up being a lot of blood in the cough. That's also causing a lot of damage to the lungs. And when the child is actually able to catch their breath, because they're coughing so uncontrollably that they can't catch their breath, you get that crazy whoop sound when they're finally able to catch their breath, which is where the name whooping cough comes from, is when they're actually able to bring the air in, you get that sound. But it's actually the coughing is the important part to the disease. And then the last stage is the convalescent stage. This is the non-contagious. Coughing decreases, healing starts to happen. It's really when we see the most danger is in the proximal stage. That's when we're having the most dire issues coming up. Would it be
smarter to just take the baby as soon as they have cold symptoms? And just kind of go.
Is that what you? You could.
You can't really give most infants that get it. They don't like to treat them right away with just simple symptoms because.
So you have to wait for it to get that bad where
So the vaccine is always a better choice, being vaccinated right away as an infant, to block that. But that's where we're seeing the problem. So we'll come back to this on Thursday. So my plan for the rest of this week is to finish this chapter up.